Good morning, everyone. Hopefully you've had a lot of coffee and some good breakfast, and we can get started. We have a great start to the day today. I'm very excited actually to introduce our first speaker, Dr. Barbara Marriage. Sorry, I don't like microphones. Dr. Marriage holds both a master's degree and a PhD from the University of Alberta. She's worked for a number of years in clinical nutrition as well as in research, and in 2002 she transitioned to the industry area. She was a senior clinical research dietitian for Abbott Nutrition, and she is now involved in their regulatory affairs section. She has a very long title, so I'll try to get this to get this whole thing right. She's the Associate Director of Global Regulatory Science Innovations and Operations. More importantly to us as dietitians, she is the current president of the Genetic Metabolic Dietitians International. We're very excited to have her doing that role for us. And she is going to be presenting this morning on nutrition and mitochondrial disease.
Thanks, Amy. And can everybody hear me? Okay, good morning, everyone. So it's, I'd like to thank the organizers. And I was thinking yesterday when I was listening to Amy Cunningham's talk about the PKU guidelines and evidence-based, and I've worked on the MSUD guidelines. So I want to make a disclaimer right now. We'll go nowhere close down that pathway with nutritional interventions in mitochondrial disease. So it's, it's such an interesting area, but it really is an area of frustration, especially for clinicians working with these patients. So what I'm going to try to go over and is looking at, what's the rationale for use and why did we come up with using nutritional cofactors and vitamins and evidence or probably the lack thereof of clinical efficacy. What are practices or what are consensus on what people are doing in the area? A little bit on the use of the ketogenic diet, and from my clinical experience in mitochondrial disease, I really didn't work with this very much, but it's another area we will talk briefly on. Kind of some just general guidelines, and also a little bit on what does it hold for the future. So these are so frustrating, and I think it's well said by Munich on, why are they so difficult to treat, difficult to diagnose. So when you look at a disorder that, it has any symptom or disease manifestation, any degree of severity, any age of onset, mode of inheritance, as well as any organ or tissue. And I think I learned that very well in the clinical practice when we had a young patient who had NARP. 3-year-old, very severely affected, so you do the long history and you bring all the family. A great uncle, 76 years old, had quite a few, heteroplasmy. If you looked at the amount of DNA that had issues with it, he should have been affected and was 76 years old, very proud that he hadn't seen a physician for 52 years. And he'd had a broken leg when he had done that. Farmer in Saskatchewan, very healthy. And yet here, this is a gentleman who had no symptoms with a great niece that was severely affected. So just a little bit kind of the cofactor treatment when you look at, why are we using all the vitamins? Where do they kind of fit into the pathway? And I'm going to concentrate just on primary mitochondrial disorders or OX-PHOS disorders and not look at secondary mitochondrial dysfunction. So again, rationale, why are we using these things? So it could be, cofactors like CoQ and riboflavin that, work in the respiratory chain. Looking at can you put vitamins in like vitamin C and vitamin K that bypass components of the respiratory chain to stimulate enzyme activity, antioxidant activity, using something like a ketogenic diet for alternate energy source, carnitine, which we use in other disorders to scavenge free fatty acids and organic acids, and then things like creatine to improve muscle function. So unfortunately, I think what we've done, and maybe it's changing a little, is I think a lot of it has been a shotgun approach to mitochondrial disorders. And so we looked at cocktails. So you look at all of these factors and you use perhaps a combination. So, when you look at when first nutritional management was looking at it, we didn't know what to do. And so we wanted to offer these patients something, so we offered them everything. So a combination, and these are ones I'm just putting that are commonly used, like all the B vitamins and, L-carnitine. But at the end, which we'll spend a bit more time, is CoQ10, which probably is the most commonly used with all the nutritional supplements in mitochondrial disorders. So what's kind of the role and why did they use it? Now, with the research that I'm going to kind of review, I'm not saying it's huge clinical basis, but just kind of what studies were done so that we started using some of these. So as we know, riboflavins involved in energy production along the transport chain, a flavoprotein precursor. It can, the thought bypass complex 1, building, that building block. One of the first studies by Bernstein in 93, there was 5 patients that had complex 1 deficiency. 2 had the myopic form and 3 had the encephalopathic form. And there really was clinical improvement. I think they used about 300 milligrams a day in the myopic form. And also then when you looked, they did a muscle biopsy 2 years or later with some of these, and it normalized the complex 1 activity in muscle. Now the interesting thing though, it had no correlation with clinical symptoms. Few more with riboflavin. Some other studies, the Schulte study, they were 3 patients from a consanguineous family and then another 4th patient, and they looked at the effect of riboflavin on endurance, on exercise training, and they had higher endurance power. And this was one patient where they did a muscle biopsy like 2 years later, increase from about 16 to 47% in complex 1 activity. Other case reports of clinical improvement. This is another paper where Olgi looked at, there was decrease in lactate after being on riboflavin, and when they discontinued riboflavin, there was some deterioration, and they also showed there was an improvement in walking. So, again, some reason perhaps that they are using it. And also when they looked at, they did on this one patient, and again, these are case reports, increased creatinine phosphate when they did NMR spectroscopy. And dosages, when you look at the reports, are anywhere from 50 to 400 milligrams a day. So what about other B vitamins? Now usually though, they're used in combination with other, like with riboflavin, etc., or they might be part of a multivitamin that they give to these patients. But they look that they may have some role to help in the respiratory chain. So they're looking at, but it's certainly not like when we think of thiamine with PDH deficiency, but they're looking, does it help with pyruvate to acetyl-CoA? Does it help with the entry into the mitochondria? Same with niacin, the function it has with NAD and NADPH. So these are sometimes used in combination with other cofactors. Another one is folinic acid. So the advantage over folinic acid versus folic acid, of course, is it crosses the blood-brain barrier. And it's this reduced form. And again, the use of this comes from case reports where they're saying some mitochondrial disorders lead to secondary cerebral folate deficiency. And the reason being, if you have decreased production of ATP, you need this ATP for adequate folate transport. So this has been used in patients that actually have been looked at CSF, and they actually are folate deficient. Now, in most cases, when you've looked at the case reports, though, they have been noted to be CSF folate deficient in Cairns-Sayre syndrome. What about vitamin C and vitamin K? So again, we know that vitamin K3, anyway, it stimulates oxygen utilization. Vitamin C used as an antioxidant. Again, It's based on some of the research where we were using it. It's a case report where they used vitamin K3, 40 milligrams a day, and large doses of vitamin C. And then they looked at NMR spectroscopy and saw an improvement in the clinical picture. But when you look at other research, the improvement wasn't sustained, and other patients with complex 3 myopathy failed to respond. So, and just a little note on their side effects with vitamin K3. So it may lead to hyperbilirubinemia and hemolytic anemia. And FDA, since 2004, has actually banned the use of over-the-counter vitamin K3. So role of antioxidants, I mean, what do they do? There's other antioxidants I'm not going to go into detail on, let's say, selenium or even zinc. And the reasoning being that we use antioxidants is with you have mitochondrial dysfunction, you have more oxidative stress. So things like alpha lipoic acid, vitamin C, vitamin E, all of these things have been used as part of these mitochondrial cocktails. And, you know, there is case reports that have described some benefits, but usually they're in combination with other cofactors like CoQ, like riboflavin, like creatine. So, you know, antioxidants are used, but usually not as a sole form of therapy. So what about creatine? And a lot of the work that's been done on creatine has been done by Mark Tarnopolsky at McMaster University, where he's really looked at a lot of patients with mitochondrial disease in the treatment. So it, you know, it combines with phosphate to form phosphate creatine, and it's a high energy source. And they have found with mitochondrial patients that they have lower amount of phosphate creatine in muscle. So the one of the first trials that was done by Mark and his colleagues, and it was a randomized control trial. It was in adult patients where they gave them 5 grams BID for 2 weeks, followed by a lower dose, 2 grams for a week. So, and they showed an increase in high intensity isometric, anaerobic power in these patients. But when you continue to look at the studies, it's very similar to a lot. It's like a broken record, I'm going to be saying. There's other studies that are not showing that they have the same benefit. So not to report all of them, but you know, positive reports have been documented in another 4 studies, but there's no benefit reported in another 2 studies. It's hard to put them apart to see whether part of it was dosage. What do you look at? What type of patients they were looking at? So, you know, as you know, with these patients, they're not a homogeneous group. And so it has been, you know, different dosages have been used, but there's been benefit shown in some patients and not in others. And what about carnitine as well? So again, it has been reported, and part of the reason I think carnitine ends up being used in these disorders is there has been secondary carnitine deficiency that exists in many of these patients. It's also a carrier across the mitochondrial membrane, so we think, will it help a bit? Case reports that have shown some benefit in some mitochondrial patients, but when we look at it, and I have all the references, is they're always in combination with something else, so it's not just carnitine alone again. And L-arginine, so L-arginine is one that's more specific, and this is been used for patients with MELAS. So in the acute phase with patients with MELAS who are susceptible to strokes, showing when they used IV arginine at about 500 milligrams per kilogram, it decreased the severity of stroke-like symptoms in these patients. And also, so in certain cases, if patients with specific disorders like MELAS, they are using oral arginine, 150 to 300 milligrams per kilogram a day, and showing that there has been some decrease in the clinical severity and the stroke-like episodes that these patients have. So the one we'll spend a bit more time on is coenzyme Q. So CoQ is an electron carrier in the respiratory chain. It's a reactive oxygen scavenger, species scavenger, most popular in the treatment of these mitochondrial disorders. And part of the reason as well is there's well-documented safety even at very high doses. So when we've looked at study, there hasn't been issues with this. And it is frequently used with other cofactors. It's commercially available in a variety of forms, but it is now more recognized that the reduced form, the ubiquinol, has an increased absorption compared with the oxidized form. Some of my PhD work, we did look at it, and as long as you had it in a lipid-soluble form, we could get the increase in the plasma levels with the form as long as it was a lipid-soluble form. So what's the clinical evidence? So this is, again, probably where I got started in this area was during my PhD work, and so part of the work, and this is some of the work that was done at the University of Alberta when I was there, and we looked at patients and we put them on a year on a mitochondrial cocktail. So we had CoQ10 at 5 milligrams per kilogram. We had a multi-B vitamin. We had vitamin C, vitamin K, plus 500 milligrams of carnitine. Now, what we were trying to do as part of the research, what I was trying to do is we were trying to look at a way to more easily diagnose or look at a blood method to look at ATP synthesis. So I won't say how long I spent in the lab trying to get those methods to work. So, biochemistry, I knew a bit, but oh my gosh, after 18 months doing the same analysis till you get it to work. So what we were trying to do is looking at ATP synthesis in lymphocytes. So with these, and we looked at before they started treatment and again at 3, 6, 12 months, we did see an increase in ATP synthetic activity after they were on the treatment. But clinically, I can't say whether there's any improvement from these patients clinically. We tried to do good histories on them. There's 3 that said, yes, we had increase in energy, we feel better, but clinically we really couldn't tell. And we had we had Leber's patients, a MELAS patient, NARP, a complex 4 deficiency, CPEO, so a kind of a smattering of diagnosis as well. The one thing that led me to believe that CoQ may be doing something as part of it also is then we took the cocktail, each individual ingredient in the cocktail, and looked at control lymphocytes in vitro to see what these individual components actually did. Now these are back in the days too where you could get all your lab buddies to donate blood. So the morning I would come into the lab and they knew I was doing testing, all my lab partners would start running away because they knew I was after them get more blood collection. But it was interesting when you looked at it, there was a dose response with the CoQ, and CoQ of all of them was the only thing that showed some increase in ATP synthesis. So what about another study? Another study that's kind of similar to what we did, and this is Matthews et al., and these are 16 patients. So the cocktail was without carnitine, but pretty similar. Now, they weren't given the cocktail over such a long period of time. They were like 2 months each, and they either had 1 treatment period or some of them they did 4 treatment periods. And they made sure, they had a CoQ that was well absorbed by looking at serum or I guess they were looking at serum CoQ concentration, so it did increase. But there was all their independent measurements of oxidative metabolism, they didn't see any difference. They looked at urine lactate to creatine ratio, they did exercise testing, and really there wasn't any clinical improvement in these patients. So then just another one as well is, and again these were patients where they had CoQ, creatine, and lipoic acid. So then it was a randomized placebo-controlled crossover study. Now they did have lower resting lactate and some other biomarkers of oxidative stress, and there was attenuation in the decline of the peak ankle dorsal flexion strength. But so that shows some kind of clinical benefit. But as you can see, it really is all over the map. And I'm just reported kind of 3 studies. There's lots of studies out there. A lot of them are case reports, shorter periods of time. So the literature really is not conclusive in regards to efficacy. There is reports if people truly are CoQ deficient, then they really will show an improvement. But, when you look at it, also, a lot of times we just look at plasma. So, do they have adequate levels in plasma, but not in muscle? It's, rare that they're doing muscle biopsies to look at CoQ in muscle, a lot of them. Also, older studies, some formulations, they may be poorly absorbed. They don't look at what type. They didn't even look at CoQ levels because back 15 years ago, there wasn't very many labs that even tested CoQ. You couldn't even get that done. Small sample size with so many of these studies. And the outcomes are so variable, and clinical features of these disorders, which we talked about. So it really is a tough one to look at whether there's efficacy. There's 2 articles that I think are, if people are interested in an overview, where CoQ therapy has been reviewed by Richard Haas, and then it's Maviar Garrido, I think, has done the other one, where they evidence of what CoQ therapy does. And there's a 2007 and a 2014, which are interesting. So what's kind of the future? Right now there is a phase 3 study. It's 4 centers. I don't know whether anybody's here from University of Florida. That is one of the centers. Toronto Sick Kids, and I forget the other 2 right now that are there. And they're doing a placebo-controlled double-blind trial because that's what's missing. We don't have that with any of these studies. So what the study will be is 6 months. The dosage is higher than has been used in some of the other ones, so it's about 10 milligrams per kilogram a day, up to a maximum of 400 milligrams a day. And these are children that they're looking at. It's interesting that these patients, if you've gone to the mitochondrial parent meetings, you can see where these patients want to try whatever. They know that there may not be efficacy, but they want to try something. So even in this study, it's interesting in that they want to take them off, or they're taking them off other therapies, but they are giving them kind of a multivitamin. It's very similar to Centrum Kids, so that because they were taking like B vitamins and carnitine, and so they, as well as the CoQ, they do have kind of this multivitamin that has vitamin C, riboflavin, thiamine, and it also has about 40 milligrams of carnitine. So it's interesting that it's taking, I think this study will take a while to complete, but at least with a randomized trial, hopefully we will start to have some more answers. Now, this isn't a nutrition one, but I thought I would just, when we talk about treatments, and I think a lot of us had hope for dichloral acetate because it really would lower lactate. There was an open label study. There's quite a few studies, but one by Bruce Barshop that, a long study over 7 years, a variable response. Then one of the first randomized control trials that was done, a crossover study, it was terminated due to DCA toxicity, and because it led to peripheral neuropathy. So DCA now has orphan kind of drug status, and it can be for compassionate use, but the use of it has really decreased after this report came out of the side effects of DCA. So here's where it gets discouraging. So really, what is the clinical evidence? And I can let you read it, but it's clear. It says and these are Doug Kerr reviewed clinical studies from 97 to 2012, and it says it's clear that although there's all this anecdotal case studies, really when you go to controlled trials, there really hasn't been anything that's proven to have an impact, and it's borne out with, all the stuff with DCA, with creatine, and with CoQ. Then, of course, the Cochrane review, there's been 2 that have done. This is the more recent one, and again, it's saying, the same, despite identifying, and these were 8 new trials that they looked at from the last time they did it, and it's really, there's not evidence of any intervention in these mitochondrial disorders. So it's a field that is just so frustrating because to study it is so difficult, and we just haven't found evidence that it's effective. So although in the field of inborn errors in metabolism, I think we're kind of used to that a little bit with treatments. So I'm just going to go review now a little bit, what are people doing then? We know that when you look at the literature, there's not really true clinical evidence. So this is one that was done in the US, and this was conducted in October 2012. And this is invitations were sent to members of SIMD and GMDI, and it's posted on the Metabol listserv. And 152 began the survey. There was 78 completers, and they were asking not just about mitochondrial disorders, but they were asking about the effectiveness as a number of dietary interventions in inborn errors of metabolism, and looking at what they use for treating primary and the secondary disorders. But I'll just concentrate on what the results were for the mitochondrial disorders. So when you look at it, and the red is yes, what we've used, and the blue is no, we haven't used it, you can see kind of it's a little bit all over the map. But if you look at CoQ, of course, a large amount, over 90 some odd percent are using CoQ. But when you look at, and another one, you look at ones that aren't being used very much anymore, like succinate, for example. So this is, have you used these modalities for treatment of mitochondrial disorders? The thing that I do find interesting with the next one is then when you look at what do they think as far as the effectiveness. So when you look at this slide, not effective is red, no opinion is blue. The ones that they say are effective are these little blue ones in the middle. So regardless that we're thinking that they're probably not a very effective modality for treatment, it's still being used, because what do we have to offer these patients? So the next one that looks kind of more of a survey was also done with there's 2 articles that are done by this group from the mitochondrial medicine. And the first one is more about diagnosis, and the part 2 of it is actually looking at what these practices are of metabolic physicians that are treating like mitochondrial disorders in the US. So again, with their surveys, there was a smaller group, and as you can see, it's a combination of clinical genetics, child neurology, neuromuscular. So there's different groups that they looked at. Now there were similarities in practice, but total lack of consensus. And just items that are used more often. And so this article is interesting to read, but CoQ basically 100%, L-arginine for strokes, again about 100% agreed that's what would be used. L-carnitine, which I was surprised with this one, about 94%, and creatine about 75%. So when you dug into also how did they start the treatment? Did they start it on a cocktail, or did they start it on individual supplement? And again, it was about half and half. And about 60%, they all had unique combinations of what they used. So they looked at how many kind of cofactors they used. So this is just breaking it down. A cocktail that has over 9 different components, about 9%. The 6 to 9 was about 20%. 3 to 6 components, about 63%, and less than 3, about 9%. And these 9%, basically, when you looked at it, they were just using CoQ10 alone. So this is a survey, and remember, these are all physicians that are treating mitochondrial patients and have experience with them. So the next part from there, because there really isn't, as we know, research, is what was done is they picked out of this group, and their names are there, about 19 specialists. And this is also supported by the Mitochondrial Medicine Society, and they did a Delphi to look at what are they recommending to use. So this is, I'm just going to go through what this consensus working group is saying right now, to the best of their knowledge. Here is what they're agreeing to use. So one of them, IV arginine, should be administered in the acute setting of stroke of MELAS. It's saying CoQ should be offered to most patients with mitochondrial disorders. Talking again, which we said before, the reduced form is the most bioavailable form, and that they should look at plasma or leukocyte CoQ levels, helpful both in looking whether they're actually taking the CoQ and also what's the absorption of it. The other one is saying lipoic acid and riboflavin should be offered. Folinic acid should be considered if you do have CNS-like manifestations, and definitely routinely administered to those that have documented deficiency. It said L-carnitine should be administered when there is a deficiency. So this is what kind of made me laugh when you look back to the other one. 94%, though we're using L-carnitine, I would bet that 94% of mitochondrial patients don't have a carnitine deficiency, but it's just interesting when you look at it. I understand when there's a deficiency, but it's interesting how common it's being used. And their recommendations also, when starting therapy, if possible, begin one at a time. But you look at it, which it's like a broken record, there's no evidence-based guidelines. These are specialists saying, this, to the best of our knowledge, this is what we're trying to do. So, I mean, it's still an area that there's, lots of work that really needs to be done. So the next area I'm going to just touch on, and I don't have clinical experience on this as far as in the mitochondrial disorder, is a good old use of ketogenic diet. And as a dietitian, you've been in the field too long when you've gone through the cycle of, in the 70s, where it was being used, and then all, newer anti-epileptic drugs came out, and no way you would ever use a ketogenic diet, and then you wait 25 or 30 years, and then the ketogenic diet again was used for epilepsy. And this isn't one article that talks about how does it work, but it's an area that I think we still really don't understand how the ketogenic diet truly works. I mean, one of the things that's always confused me with it is that how does it still work when you discontinue the diet sometimes and they stop having seizures? Their metabolism should go back to the other way. So it's just an area that I find fascinating. And this was an article that really was just saying, how does it work? And so when you look at it for mitochondrial disorders, is it working with the antioxidant role? Because they're saying it has increased production of antioxidants when people are on the ketogenic diet. Activation of ATP, sensitive potassium channels, inhibition of a manual target rapamycin pathway. Different mechanisms which may be why the ketogenic diet works. But what about in mitochondrial disorders? And I'd like to acknowledge my friend Kathy Camp, who did some of the work on looking at this when there was a meeting in December with NIH. And prevalence of epilepsy and mitochondrial disorders, we really don't know what the prevalence is. There's seizures that's reported in, about half, 35 to 60 of biochemically confirmed mitochondrial disorders. And then from Cleveland, Parikh had said that about a third of patients with refractory seizures had mitochondrial dysfunction. So, there is evidence that there is seizure disorders, as we know, in this population. But what's the research that shows how it helps? So most of it seems to be in more on complex 1 deficiency. Kang et al. Said it was, safe and effective. And they had 14 patients. With 9 of these patients had complex 1, and there was, a complex 2, 3 of them with complex 4, a combination, 1 of them with both complex 1 and 4 deficiency. So after the ketogenic diet, 10 out of 14 were either seizure-free or had a 50% reduction in seizures. But 4 out of the 14, there was no benefit whatsoever. Lee, another one, positive results. And this was a large group of patients, 40, I think there was 48 patients, and they looked at the ones that 24 of them that had intractable seizures. And with those, about 18 out of 24 were seizure-free, and then 6 out of the 18, about a 50 to 90% reduction in seizures. And there's many other case reports. A MELAS patient with ketogenic diet and supplements, a pole-related epilepsy. This wasn't a ketogenic diet per se, the really restricted one, but it was a low glycemic index diet. So there's case reports saying it may help with seizures. Now, working in the clinical setting, dietitians are so well aware of this, but this is not an easy diet to do. It's really time-consuming. It's tough for families. It requires a lot of work. Now, long-term also, we may know that there's effect with bone density, etc., with long-term with ketogenic diet, but there has been at least some literature saying in certain cases it may be helpful in these disorders. So what about general guidelines? So trying to look at, exercise and just good nutrition. So there is some evidence that exercise leads to an improvement, of course, in mitochondrial function. Studies that have looked at with mitochondrial DNA problems that you can change the amount of good versus bad healthy mitochondrial DNA. Again, when you look at what's being done, about 78%, again, this is from the mitochondrial medicine group, again, do use exercise. But I think also, when I look at my group of patients or the group of patients that we dealt with, some of them were very physically disabled as well. And so I think with exercise, it really has to be what's applicable to that patient group. We had one of our patients who we were really trying. He was a little overweight, and you know how that's an issue with mitochondrial patients. You can't exactly put him on the diet. We encouraged him. He really had to get out and do more walking, do more exercise. Of course, about the second time he did it, he had rhabdomyolysis, ended up in a merge. And so then you're thinking, like, how much exercise can, these patients get? And it really has to be something that's not just general guidelines, but individualized to each patient. Now, what about nutrition just in general? And really, there's no specific diet. There's nothing you can do with the diet that's really going to totally change outcome other than, healthy nutrition, etc. Perhaps complex 1 deficiency in a ketogenic diet, there may be something. It's really individualized. If you have patients that have GI complications with it, slow gut motility, then I think it's helpful that you look at limits of anything that's going to slow gastric emptying, limit excessive fatty foods, look at with small feedings, limit fasting. Where these patients, or like any metabolic patient, you want to look at limit fasting. They get into trouble with stress or with fasting. Small frequent meals may be recommended. That seems to be helpful for a lot of them. Hydration, again, is very important. IV therapy if they can't take oral intake. And I think really being proactive on making sure that when they're under stress that they get acute treatment. I think, we know it so well for, let's say, our propionic and methylmalonic and all these other disorders, but I think maybe it's my own experience, we weren't so active with our mitochondrial patients. We didn't know how much they might get in trouble. And so I think it's something, especially with more of the severe phenotypes, that you really look at that. And again, the whole use of supplements. I really wish I could stand up here and say, here's what's recommended, but that's, basically what is out there right now is just kind of the guidelines from the group that looked at it, but I think it's very much individual because we certainly can't base it on good clinical evidence. And then what's in the future? I mean, it would be wonderful to have more placebo-controlled trials. I know how difficult they are in this type of population. The one study I think that is given some hope is that it's the name is EP1743, and it's a parabenzoquinine. It's targets repletion of intracellular glutathione. A single-arm clinical study's been done. 10 patients were enrolled. They've been treated for 6 months. These are all patients with Lee syndrome, and they're shown some reversal of disease progression. So, I'm hopeful that this is a way we're going where we could have something that targets specific disorders, because I think we're trying to take kind of a shotgun approach with all this heterogeneous population and trying to look at one treatment for all of them. So just in conclusion, just some resources that I think are helpful. These are just kind of general kind of review articles that talk about, approach to mitochondrial disease, and the ones I was talking about, the consensus statement where they looked at it, one with Billy DeMauro, and a critical approach where he kind of does it as a question answer. What's the kind of pros and cons of using some of it? So these are kind of overview, which I think may be helpful. And with that, I'll leave it open to questions. Thank you. Hans, please. If you didn't come up, I would have been so insulted. Disappointed, insulted, everything. Oh.
I don't feel bad. He couldn't do it either.
Yeah.
So, I want to share just a little bit of experience because we don't really have evidence, we have experience. But, and this is based on seeing a couple of patients who have mitochondrial DNA mutations, generally in tRNA genes, but also one in the cytochrome B reductase gene. Right. And really responding to the cocktail recommended and tested by Tarnopolsky in that Rodriguez 2007 paper. There they had a couple of patients with MELAS who seemed to be the ones that responded. So, when I ran to these patients, I checked MetHabel. If you're brave enough, that's always useful. And I got responses from Tarnopolsky and Bruce Cohen really recommending that CoQ10, alpha-lipoic acid, creatine. And my few patients now, up to 4, have really done better when they went ahead and complied. The issue with recommending CoQ10 is the cost, which is going to be in the order of $60 a month or higher, even if
higher. Yeah,
it's a low dose.
When I looked at it, it was like about $20 to $60 per 100 tablets or something. So that's the thing, is not getting it covered. I mean, I was very lucky when I was in Canada because we could get all of it covered. So we just slid it into the genetics budget with our low-protein foods and medical foods. So it never was an issue to continue them, even if you weren't sure of clinical efficacy.
So, and we're not that organized. One more thing, just, Pearl.
You don't pay us enough taxes, so that's why you don't.
One thing to know is that the Kanika manufactured products, so Kanika is the manufacturer in Japan, and to my knowledge, all of the bioactive CoQ10 comes from Kanika, and there's a list of their brands on the website. So it's not just Tishcon, which tends to be a little bit expensive.
Right.
Some more affordable brands, no endorsement, but Jarrow and Cunol. Cunol is at Costco and the vendors, and it's both a liquid and a pill form, and that's been useful for us. We know it's bioactive.
Yeah, thanks, Wade.
So thanks for taking on such a difficult topic.
I got the short straw.
But you did a great job of being honest about the data. I'm wondering about the recommendation for oral arginine in MELAS. The amount that you showed seemed to be sort of the same amount of arginine I might eat in a normal day, and I wondered if there's a difference between dietary arginine so arginine from intact protein, and a supplement.
There actually shouldn't be as far as absorption. I mean, really, you would absorb it the same way from most foods. So I really, is it just over and above what you would normally get in a diet? I haven't actually figured out, but yeah, I think they were giving them
like
500.
150 to.
Well, they gave them, I forget, 500.
It just didn't seem to be that high of a.
Well, it was a range from 150 to 300 milligrams per kilogram per day.
Doesn't that seem like that's about the amount I would normally eat?
Yeah, I think it'd be a little higher. I'd have to actually.
Really?
Yeah.
Okay.
So
Thank you.
It's a good question. But I mean, a question also to the audience, I mean, how do we, if we feel that CoQ is, let's say, effective, how do we get so that we get coverage for it? Like, I mean, it's such a difficulty even with medical foods. I mean, how do you ever get coverage for it? I mean, that's what's just so frustrating. I mean, even when I was doing my research and when we were trying to get kind of a wholesale source through the hospital so that I didn't have to go to the health food store to actually buy the CoQ. And we couldn't, the hospital said, no, it's not effective, but I could go to the health food store, buy it, put it underneath the budget and somehow get it, but we couldn't get it from another, source. And so, it's just such a frustrating because patients, there's lots of, as we say, anecdotal studies and people that it's effective, and yet it's very frustrating that we can, get coverage for it. So that's why I think if we do the clinical studies and it's shown in placebo-controlled trials, maybe we have some hope of getting some coverage for us. So, anything else? Thanks.